Today we are going to talk about upper GI bleed. Upper GI bleed is bleeding above the level of attachment of ligament of trades, duodenal fracture, and include esophagus, stomach, and duodenum. Causes of upper GI bleed. Esophageal causes include esophagitis, esophageal varices due to liver cirrhosis, portal hypertension, esophageal malignancy, and esophageal perforation secondary to Mallory-Weiss tear and Bohr-Haave syndrome. Stomach causes include gastritis, peptic ulcer disease, portal gastropathy, secondary to portal hypertension and cirrhosis, and connective tissue diseases like Ehlers-Danlos syndrome and gastric antral vascular ectasia, and gastric malignancy include adenocarcinoma. Duodenal causes include peptic ulcer disease, H. pylori infection, arteriovenous malformation, vascular disease more common at right colon in the lower GI bleed but can occur in duodenum. Erosion of abdominal aortic aneurysm by nearby ulcer. Most common cause of upper GI bleed is peptic ulcer disease and varices in esophagus. Posterior epistaxis can mimic upper GI bleed. Presentation. Patient will be present with hematemesis and melena. Melena is black tarry stool having offensive smell. Loss of blood volume leads to hypotension, which leads to activation of sympathetic system and increased heart rate. Patient will be pale and having cold extremities, flat jugular vein and IVC, anemia, thrombocytopenia, and orthostatic hypotension. Diagnosis. History and clinical examination will help to diagnose. Assess patient's hemodynamic status. Patient will be pale, having cold extremities, increased heart rate, decreased urine output, and raised liver enzymes. CBC shows decreased RBCs and decreased platelets count. Deranged INR, ultrasonography to see liver status, coarse texture with ascites and portal vein diameter. Upper GI endoscopy, pill camera endoscopy and vascular studies, arteriography, CT angiogram, and tagged RBC scan. Management of upper GI bleed. In emergency, first of all, resuscitation. Maintain 2 large bore IV lines. IV fluids, normal saline or ringer lactate, 1 liter IV stat can be repeated based on blood pressure, urine output, and pulmonary edema. If HP is less than 7 gram per deciliter, transfuse blood. 1 pint of packed cell of RBC will increase 1 gram of hemoglobin. If patient is hypotensive, systolic blood pressure less than 65 mm of mercury, in spite of IV fluids and blood, add vasopressors like norepinephrine and vasopressin. Give IV proton pump inhibitors. These are superior ability to maintain a gastric pH at 6, protecting an ulcer clot from fibrinolysis. Dosage is 80 mg IV bolus followed by continuous infusion at the rate of 8 mg per hour for next 72 hours. Octreotide sandostatin 25 to 100 microgram IV bolus followed by continuous IV infusion of 25 to 50 microgram per hour for 2 to 5 days. Treatment of specific cause. If patient is taking anticoagulant like warfarin or rivaroxaban, reverse with vitamin K and fresh frozen plasma. Patient is having varices, treat medically like sandostatin, antibiotics, ciprofloxacin and ceftriaxone. Surgical options include band ligation, sclerotherapy, and black hemo tube. For perforation, keep the patient NPO, pass nasogastric tube, and surgical procedures are the options. Mallory-Weiss tear, antiemetics can be given, clipping cauterize the area. And for malignancy, treat with surgical resection, chemotherapy, and supportive care. And for peptic ulcer disease, treat with cautery or clipping the ulcer area and treat H. pylori infection. And for aortoenteric fistula, treatment is cardiovascular surgery.